Hi, everyone. I'm Deb Flashenberg. Welcome to Yoga, Birth, Babies, a podcast produced by Prenatal Yoga Center. We will be diving into everything prenatal yoga, birth, and baby related, hoping to inspire, educate, and empower you through your journey into motherhood. Thank you for listening.
Hi, I'm Deb Flashenberg, and I'm your host of Yoga Birth Babies. And today we're going to talk about breastfeeding. Did you know there is a whole new subspecialty called breastfeeding medicine? I will be honest, I did not know that until I was speaking with our guest. But our guest, Dr. Leigh Campbell, is going to tell you all about that. It is a new subspecialty, and it goes really hand in hand with IBCLCs and supporting new parents who are breastfeeding. But what Leigh jumps into so beautifully is she talks about breastfeeding in a way of understanding how the baby actually gets milk from the breast and how that differs from bottle feeding and how sometimes it's misunderstood. We're also going to jump in to talk about, should you be in pain when breastfeeding, and what happens if you're concerned about baby not gaining weight. And then we, of course, jump into the controversial topic of tongue tie. And we also talk about understanding what milk supply looks like in the first 2 weeks. And then also, if you take an epidural, what you may expect in some bumps in the road and how to get past that. Leigh has so much amazing information, and she's probably one of the kindest, most passionate people I know about breastfeeding. I'm so excited for you to hear this conversation. But let me tell you a little bit about Leigh. So Leigh Campbell, she's an MD and IBCLC, and she's among the first inaugural cohort of board-certified breastfeeding and lactation medicine physicians, and she's also board-certified neonatologist and pediatrician. She founded Mississippi's first lactation medicine clinic at the University of Mississippi Medical Center in 2022 before transitioning to private practice. Dr. Campbell is the founder of Bloom and Grow Lactation, and in the studio adjacent to her clinic, she teaches the PYC method of prenatal yoga. Leigh and I met back in 2021 when she did our teacher training, and I have not forgotten her. She has just an infectious smile and laugh and is probably one of the most calming, grounded people I know. If you are on a breastfeeding journey and you have hit some bumps or you are heading into that period, I'm so excited for you to hear this conversation with Leigh. She has such great supportive information. Now, before we get to my conversation with Leigh, I always love to give updates about what's happening at the studio. So the best way really is to check out our website, prenatalyogacenter.com. There you will find our schedule for our in-person, our online, our on-demand classes, our workshops. We have childbirth education in 2 different manners, a deep dive, a 3-hour quick express. We have obviously a breastfeeding class and newborn care, so much. Everything that we can do to support you before and after your pregnancy and your early parenthood. But we also have a very thriving prenatal yoga teacher training, the PYC method training. And we offer it in person once a year and online 3 times a year. So if you are excited about learning our particular style of prenatal yoga, jump in, check out our program. As I mentioned, we run it 4 times a year, and I just love working with passionate teachers and bringing this method to each community out there. I'm really excited for you to learn about that. Again, everything's on our website, prenatalyogacenter.com. And then 2 final things. A big thank you for those that have been listening and have been leaving reviews. And if you haven't, please take a moment to do so. I know it may seem silly to leave a review, but it really helps people find us. And we're all about creating more support for the community. And when we have more reviews, it helps people find us. And then the other thing is another thank you for those that have reached out with either birth stories they want to share, or if you think you're going to be a good guest, please fill out the application, and people have done so. And I really appreciate it. And another thing people have done that I appreciate is I always ask for topics. If there is a topic I haven't covered, or maybe you want me to cover a different angle, reach out, and people have done that. And it's helping me make sure that we're bringing back what you want to hear on the podcast. So another thank you. All right, that is enough of me. Let's take a quick break. When we come back, please enjoy my conversation with Dr. Leigh Campbell. Hi, Leigh. How are you?
Hi, I'm doing great. Thanks for asking.
I am really excited that you are here. And I know the funny thing is we've worked together in other ways, but I've never got to really pick your brain as a doctor and as a IBCLC. And I didn't even know there was something called breastfeeding medicine. So I'm so excited to have you be the speaker today. So thank you.
Oh, thank you. It's so great to reconnect with you. We have lots of fond memories together.
Absolutely. All right. So before we jump into talking about breastfeeding and all that fantastic stuff, why don't you share a little bit about yourself? What led you to medicine and breastfeeding medicine? And I'm going to be honest, as I mentioned, I had not heard that term before. So for the parents out there, can you also talk about what is breastfeeding medicine and why families should know about it? That's a lot that I just threw at you.
Yeah, of course. Well, we're super excited. There's now a subspecialty in medicine that honors the breast and breastfeeding. It's a separate organ system, so it's pretty important. But yeah, I graduated from med school a little bit ago. Do I have to tell you what year?
You do
And
not know.
at the University of Mississippi, and that's actually where I met my husband. And then I practiced medicine as a pediatrician, really residency for 3 years. And then I went to the University of Alabama, Birmingham, where I did my fellowship in neonatal and perinatal medicine. And then at that time, I was also pregnant with twins, and they were a long IVF story. And so I was very large, rounding on my last few months of my third year of fellowship. But that is, when that I really experienced challenges. Of course, I knew the magic of human milk, and especially working with premature babies and critically ill babies in my training, and seeing what an impact it had on feeding and outcomes in general, morbidity and mortality. So it was already a QI or quality improvement interest of mine. But once my babies were born, my twin babies, which thankfully I was able to keep them with me, and they did not have to go to the NICU. I was very fortunate with that. I put them to my chest and didn't know the next step.
You're like, here you go. Figure it out.
And quickly realized I needed help. So that was kind of really what, built my passion in that journey, and really just so desperate for somebody to help me breastfeed these twins. And of course, there was a lot of, support, but also, realizing that they were twins and you probably won't succeed, and it's okay to give formula, and, make sure you're resting, and, you need to recover from birth. So formula is just as good. So it was, my passion to breastfeed, but I couldn't really find the support. It's almost as if people were protecting me. But I had this desire to, find somebody who could support me on that journey. So yeah, that's really what, left me in such an impact, and all the things that, I was looking for. It was then my goal to offer that to families someday.
That is amazing. How old are your twins?
Oh, they're 14.
Oh my goodness. That is why we get along so well. We have 14-year-olds together there. All right. That makes a lot of sense. So talk a little bit about what is breastfeeding medicine. You said it's its own specialty. Is that the right word?
Yeah.
Okay.
Yeah, so it's a really great question. So for so long, OBs and even family medicine physicians have really had to cover the subspecialty of breastfeeding and lactation medicine. So challenges with breastfeeding, mastitis, low milk supply, and they already have schedules that are so demanding, and so they've been covering this area, but what we really needed was to distinguish breastfeeding and lactation medicine as a subspecialty. And that really happened a few years ago. So there was this amazing pioneering group of breastfeeding medicine physicians, and many of them came from the Academy of Breastfeeding Medicine, and have been established there. That they felt that breastfeeding medicine physicians needed to be their own subspecialty so that they could be recognized as a subspecialty. So what they formed was the North American Board of Breastfeeding and Lactation Medicine, and so I was fortunate to be one of the inaugural groups from this program, and it really establishes quality of care, really a focus on access. And so it really distinguishes breastfeeding and lactation medicine as a subspecialty, much like if you see a urologist or if you see a GI physician. So it's a subspecialty within medicine that works closely with IBCLCs. But the difference is that a breastfeeding medicine physician can take care of the mom and baby, or the dyad, and they can evaluate, diagnose, and treat. So that's the main distinguishing.
Do IBCLCs not do that?
Correct.
What do
So their
they
scope
do?
of practice.
I'm so confused. I thought they did. Okay.
It is very confusing. Yeah. So IBCLCs are, amazing, individuals who have really dedicated their lives to helping breastfeeding and lactation dyads, but they're in more of a supportive role in the sense that they are doing things like helping with latch, following weight, helping with pumps, helping flange sizing. And then if they suspect something that is consistent with a medical diagnosis, then they will, basically that care will then be transferred to somebody who is medical, who can then work up, diagnose, and treat. And so we complement each other very well, because if somebody needs medications or they need labs or they need a referral, then that would be a reason to escalate care to then a physician or a practitioner.
So this is so new to me, and honestly, you're the first one I knew, or person I know that is breastfeeding medicine specialist. How prevalent is this in other areas? Because I feel like in New York City, you would think we're so densely populated with the medical system. I haven't heard of any other breastfeeding medicine doctors. Is it because it's new? Is it just not out there yet?
It's very new. In fact, it was, I think 2022 was when I became board certified, and I was the first group. So it is very new, but they are, they establish standards for certification, and they advance excellence in patient care. And it's really, they're being an advocate for breastfeeding individuals and their babies. And so it's really helping it's really a field that's new. It's certainly been practiced by, different physicians in their day-to-day practice, but it is now seen as a subspecialty. So now there are physicians that strictly practice breastfeeding medicine, and that is their subspecialty, which of course is taking a careful evaluation of mom and baby, medical diagnoses, medications, and all the things that can interplay that can affect the interaction of the mom and baby or the dyad and their breastfeeding goals or success.
So I will pick up where I wanted to go, but I do have a few more questions.
Yeah.
So because IBCLCs typically do home visits, would that be the first step for a new parent if they're having latch issues? Because I just remember being a new parent, and the idea of more doctor visits and having to get everyone out of the house is daunting. So knowing an IBCLC can come to one's house, would that be the first step? And then if there's more issues, then they go to the breastfeeding medicine specialist?
Yeah, it's a great question. So certainly by number, an IBCLC is going to be more accessible in the community just because there's more of them. So for instance, I'm the only one practicing breastfeeding medicine in Mississippi. So I'm the only physician that's practicing it. Correct.
Okay.
So Yeah, so IBCLCs are integral, to that community care, and in that initial visit, and really it starts in the hospital postpartum, because IBCLCs can make such a difference in those first few days postpartum, especially in compliance with baby-friendly hospitals. So we actually don't have a lot of IBCLCs in the community, at least in Mississippi, that do home visits. We certainly have
Oh,
some,
interesting.
but many of them have clinics, more standalone clinics, or they're having they're a nurse in a pediatric office and they have an IBCLC, and so they're complementing the care the pediatrician is given. So they're certainly first line, but it's the idea of supporting them, when they are running into complications with the diet, and helping them, and realizing that there is a medical confounder in the care that needs to be addressed by, a physician that can then provide physician level care.
Interesting. All right. So you actually just opened my eyes. I love learning things. You opened my eyes to a whole new level of support for breastfeeding, which is really exciting. And I'm going to do a bit of a deep dive and see if there's any breastfeeding medicine specialists in New York. And I'll make sure that's in the show notes. I may not find one, but I may. So I'll let you know. All right. So I'm going to pull us into diving into breastfeeding, because I know that is one of your passions. You know a lot about it. And so I have several questions that are kind of span quite a bit. But the first one, I want to talk about breastfeeding hurting, because I have had many students be like, well, it's supposed to hurt, right? So let's kind of talk about that. Is it supposed to hurt? If it's not, what's going on?
Yeah, so no, but there's certainly going to be potentially a period of being uncomfortable while this skill is learned. Breastfeeding may be natural, but it's certainly skill based, and that's skill based of mom and baby and how they fit together. So if something is hurting, it means something needs to be adjusted. So some sort of support needs to happen, and that is almost really every breastfeeding dyad needs some sort of support, at least in the first few days, but especially primogravids or moms in their first time babies. So there are so many different, things that you can address when it is painful, but I found that it's almost always latch. So I like to call it fit and hold, but latch and positioning is, you can almost always correct pain and discomfort with working on latch. And a lot of that is just kind of understanding the biomechanics of how a baby feeds. And, we've done a lot of bottle feeding and formula feeding over the last few decades because of formula companies and the influences they have had. And so we've lost a lot of community support, families breastfeeding in front of each other, cousins, aunts. So a lot of that community that used to be there is no longer there. And so we're, having to rely upon IBCLCs and peers to help complement that. But there's just a misunderstanding of, how a baby comes to the breast, and much of it's extrapolating from bottle feeding, which is more of a kind of a suck, positive pressure removal of milk, as opposed to breastfeeding, which is actually really forming a vacuum. And so instead of compression, squeezing, stripping, taking the tongue and stripping the nipple, it's actually more of a vacuum that a baby creates, where they fill their mouth with breast, and then they hinge the jaw up and down, and then that negative pressure that's generated from the jaw hinging actually creates a vacuum effect. So the nipple itself, which has the ducts in it, dilates and milk sprays. So it's not a compression, and if it is, it hurts. And so helping a mom or a parent-baby pair come together at the breast and transition into that type of feeding where it's, more vacuum generated, is what can help with a lot of nipple pain, nipple damage, cracks, fissures that we often see. And a lot of this work is pioneered by some of our Australian friends. So Pamela Douglas, and then, certainly Donna Geddes has been really, done pioneer work in this. And a lot of that's from MRI studies, ultrasound studies. But yeah, they do some amazing work in Australia that's really helped me in my practice.
So what you said really, and things, I've watched breastfeeding, I've breastfed, I've watched bottle feeding, but the way that you explained it had a very different picture. And I think that many of us don't think about the difference in mechanics, that with a bottle, you just stick it in their mouth and they really have just the nipple and they're just kind of sucking away. But with the breast, and this is something I was surprised how much goes in their mouth. It's not just the nipple, like it's really, there's a lot more. Like you said, the whole breast goes in there. So I think because maybe it's not explained, or we often just think about nipples, like the nipple of a breast and the nipple of a bottle is the same. I think that could create that misunderstanding and why breastfeeding could hurt. Because you said, like, you have to get so much of the breast in and then it's the jaw as opposed to just like a suck, 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 suck. So
Yeah.
that makes a lot of sense.
And it's beautiful when a baby comes to the breast and milk starts to be transferred. It's this gorgeous, like, hinge of the jaw and these beautiful ka sounds. And there's no stress cues in the baby, and they're very regulated. And it's really just the most beautiful thing to watch. I never get tired of watching it. But I think the trick here is that we really have to teach babies to use their own intrinsic reflexes to really transition into this vacuum where milk is then transferred. Because a lot of what we're taught after a baby is born is just kind of put the breast in the baby's mouth. It's more of a mom or a parent assisted feeding where they're more directing the feeding. And so it's kind of waiting for the mouth to open and putting it all in there, which really over time can almost set up, is what we refer to as like condition dialing up, where the baby is wanting to bring the breast into their mouth on their own independently, and the breast is just kind of following in when they're not ready. And so you can start to see, or at least what I will see, after discharge, is maybe putting the breast in the baby's mouth and getting them to suck may work for a few days. But after that, once the milk transitions and the volume has increased, then that doesn't work anymore. And a baby really has to figure out on their own how to generate that vacuum, because that's not something we can really teach them. And so they really need to go through that familiarization stage where they're smelling the breast, tasting, licking, and coming very familiarized with it, using their hands. And then, once they localize to the nipple, which does, help them localize, then there's almost this pause that they have. And then they'll make this big, vacuum effect where their cheeks and chin are very close to the breast. And that deep face barrier is then what allows for this breast tissue to then fill the baby's mouth. And then from there, when the jaw hinges and there's that negative pressure, is when there's milk transfer. So it's the biomechanics of infant suck is extremely complex. It's very different than like a cow, right? Where they just have a cistern. So all you have to do is, yank the cow nipple down. The biomechanics of a human feeding is very complex. And so
does the baby, I can imagine, I'm thinking like a listener, and they're like, okay, how do I get my baby to learn this? So how are they just instinctively, like, you just present the breast? It's funny I'm asking this, and I breastfed 2 kids, so you would think I would know this. I don't. I feel like I have no idea how I did it.
So I'm so glad you're asking, because babies are brilliant, and it is incredible. I see it every day in clinic that if you offer positional stability, so in a way that a baby has stability, so mom's body becomes, or parent's body becomes baby's body, they are connected as one. There is stability in the core with the hand wrapping around and the head resting on baby mama's forearm or parent's forearm. That then leaves the head free. So there's positional stability essentially in the core, the trunk of the baby, where the head is free to then familiarized with the breast and smell, taste, touch, localize. And then they really go through this, motor patterning where they just draw the breast in, and then every subsequent swallow is a deeper and deeper latch. So you don't have to put all the breast in on the first, sucking, because they incrementally draw more and more breast tissue into the mouth every time they swallow. So it is really about positional stability. And once a baby feels safe by being held by their mom, their parent, and becoming one, very much how, baby used to be in utero, then that stability then allows for them to seek and find the breast. And what you really want to avoid is pushing the head into the breast, because that's when, they're not able to go through those familiarization steps.
I think that happens a lot. Like the baby smushes in. And I actually think I was kind of taught, like, get the nipple ready. There's a certain place in line with the face, and then kind of boom, smush the baby in. And it sounds like that was not the correct information.
So I think we were all taught that way. And it's just this evolution now, and kind of understanding the biomechanics of infant suck and then applying it clinically, that it just, at least in my practice, has made all the difference in the world, for latch, discomfort, pain, milk transfer, weight gain, troubleshooting low milk supply. And again, I can't give enough credit to, Pamela Douglas and Donna Geddes and their work from Australia. So it's been instrumental in my practice for sure.
Okay, I want to take a break. When we come back, I do actually want to talk about painful feeding, slow weight gain, and then I'm going to bring up a very controversial topic, tongue-tied, because I feel like that was not around for many years, and all of a sudden I'm hearing so much about it. So let's take a break, and when we come back, we'll jump into that. We'll be right back.
REI Co-op knows when you're up at 4:30 a.m. on a Saturday for a long run, and you're actually excited, not everyone gets it, but we do. At REI, we're here for people who get outside. Gear up for your next run in-store or at rei.com.
Okay, so we are back. So let's, start with tongue tie, because I'm guessing that ties into painful and slow weight gain. So I'll just hand it to you. Talk about tongue tie. Why is it new? Is it new? Is it just something we haven't heard before? What's going on with that?
So it's a great question. And you're right. It's very controversial, which makes me, pause and be very careful in my conversations with families, because I certainly don't want to discredit anybody's journey where they have experienced, significant improvement after a procedure on their breastfeeding journey. So I just want to acknowledge that. But this kind of going back to the basics of really the anatomy and what is a frenulum. And so, frenulums, we were born with them for a reason. They stabilize our tissue. And if you think about the tongue, it's essentially a hydrostat. It's not really connected to bone, right? It's just this kind of muscle that is in the mouth. And so the way it is connected to the floor of the mouth is essentially mucosa. So the floor of the mouth kind of continues under the tongue. So it's this, continuum. And so what we used to think was this just really discrete band when somebody would lift up their tongue and you could maybe see a quote band underneath is not truly a discrete band. It's actually an infolding of tissue. So at the, this goes back to Nikki Mill's work, who actually, did some dissections on infants' mouth and explored the floor of the mouth and what that looked like. And it's really, when you lift the tongue, a tinting of mucosa, sometimes fascia, and sometimes the genioglossus muscle that tints up, if you can imagine lifting the tongue. So it can be one or all of the three. So it can be mucosa, it can be mucosa plus fascia, or it can be mucosa plus fascia plus the genioglossus muscle. And so it's really this this continuum of this glorious, structure of our mouth that's adding some stability, because otherwise, the tongue doesn't really have an anchor. And so, you can imagine that some stability while feeding and talking is actually a good thing. That's why we have this discrete structure of the frenulum. But, and certainly we know in the past, we heard stories of midwives with long pinky fingernails who would, if there was a very anterior placed frenulum or a frenulum that has gone in so far to where it's anchoring the tip of the tongue, then we've heard stories of midwives that would
seriously, they just go in and like swoop, they just go.
Yeah. Exactly.
I have a friend whose tongue, this is really funny. I wonder if she'll listen to this. She showed me that is it the frenulum? That's the bottom thing.
Yeah.
Is so tight that it creates almost like a heart at the tip of her tongue because it pulls the tip in so much.
Yeah. So that's very, quote, anterior, correct? Like that's kind of, we have used this terminology, this anterior and posterior kind of frenulum or, tinting of tissue under the tongue, when really it's a continuum. There's not really an anterior and a posterior portion. It's really a continuum. And we all have glorious variations of that and how we are born. But when if it is truly at the tip of the tongue, like you've described your friend, we do see that can affect breastfeeding. And so what we do know is that we are recognizing it. We're doing oral motor exams, and we have missed many of these anatomic variations that could impact breastfeeding, by just not doing an exam and not looking for that. So at least we're aware now, but the pendulum has really swung, and, we know that frenotomy procedures have gone up tenfold over the last, 15, 20 years. And that is when, there's a lot of misunderstanding of how to proceed when you do see an area of tissue under the tongue that is very prominent, because there's not really any validated standardized tools that truly defines a, quote, tongue tie, which is, certainly how we hear it. For my patients, they'll come in and say, I need to be evaluated for a tongue tie. But it is so complex, as we talked about the complexity of infant feeding, that it's not just, cupping the nipple and stripping it. And we kind of talked about that earlier. It's more of the jaw hinging that's actually creating the transfer of milk. And so we have to be very careful when we see something anatomically, extrapolating that into the complexity of infant feeding without looking at the other things. So thinking about milk supply, thinking about, is there a torticollis, or is there infant head positioning that's affecting latch? And so there are, including how is the baby feeding? So when the baby does come to the breast, what does that look like? And what is the function of the tongue, like on an oral motor assessment? So you really need all these things instead of just looking at the frenulum and saying that needs to be cut. A dyad deserves to have a comprehensive evaluation before we jump to a surgical procedure.
So let me ask, do you think that too many babies have had the tongue tie procedure where it is cut? And do you think that pain or slow weight gain has made people jump to, it's probably tongue tie? And this kind of goes back to that question of maybe an unnecessary procedure.
I do think we have swung that way. And a lot of that's just from my experience in clinic. And I think that we're even seeing this being done in the hospital before a baby, goes home, which you can argue before mom's milk even transition. How can you truly evaluate, suck, swallow, breathe when there's just colostrum there? There's not even really any volume. So jumping to a procedure before a baby's milk has even transitioned, before you can even evaluate how a baby's feeding at the breast seems, like that is something that I feel like, we could wait on to then see how the infant parent pair come together once the milk transitions. So I do feel like that, we have, kind of swung the other way because I've had babies in clinic and, it's anecdotal, but certainly where parents are definitely not wanting a procedure and they clearly have very, anterior frenulums all the way to the tip of the tongue, and they actually feed beautifully. And if you can imagine the biomechanics of infant suck being more vacuum generated, then that truly does make sense. The tongue's certainly there to stabilize, but it's that hinge of the jaw and the filling the mouth with breast and the dilation of the ducts and the spray of the milk that really helps with milk transfer. So I think it just is, what I guess I would recommend if you are worried about pain, you're worried about milk transfer, make sure you're seen by somebody who's experienced, and then involve your pediatrician, your family medicine doctor, your IBCLC, and don't jump to somebody who's just going to do a procedure. You deserve a comprehensive evaluation by somebody who's experienced. So I think that's kind of where we've gotten to. It's more of a reductionist way of thinking of, here's something that needs to be cut, instead of really evaluating the baby parent pair.
And
And
that
I mean, I
makes a lot
certainly
of
do
sense.
frenotomies, but it's one of those, conservative measures first.
I appreciate that. All right, I want to jump to something you had mentioned about, and this might be new because, again, if some folks had not really been around babies, they may not know that colostrum comes in first and then the milk comes in. So can you talk a little bit about those first 2 weeks after birth when it comes to milk supply? What should parents understand about that window of time?
Yeah, it's a great question. Those first 2 weeks are really dynamic and can be really scary without the right support. Just much like as I put my twin babies to my chest and felt like, oh, this is just how I do it, and realizing it was so much more complex than that. But certainly when the first milk is colostrum, or we call that, you might have heard it lactogenesis 1, or now we call it secretory differentiation, then at about day 3, the milk changes. So the lactocyte, which is the milk-making cell of the mammary gland or the breast, is actually pretty leaky initially, and those tight junctions then close, which are the cells that surround the lactocyte, and the milk then transitions into a more of a mature milk. So the initial volumes in the first 3 days are, a teaspoon or maybe a tablespoon, very minimal before that secretory activation occurs, which is, we know as, quote, milk coming in.
Mm-hmm.
And so once that happens, the volume dramatically increases every day from there on out. So by 72 hours, your milk should have transitioned. You should start to see some volume there. If it hasn't, then we have delayed secretory activation, which needs to be addressed. And that's when we need to get somebody involved who understands, the breast and the endocrinology involved and how the milk transitions. So you need some sort of care at that point if your milk has not transitioned. But so really after that, it exponentially goes up. And so every day that volume is building and building and building, but it's building also not just because your milk is coming in, but because babies frequently removing milk. So they remove milk constantly in the first, weeks of life. It's almost like everybody feels like their babies are cluster feeding when really, indeed, they are. Essentially, when they're awake, they really need to be feeding. And so it's that, constant, frequent, flexible milk removal that then gives you these prolactin surges, and prolactin surges are what you need to make milk. And that really happens with suckling and milk removal.
Okay, I want to ask a question. I hadn't even prepped you for this. I'm just throwing it out there. But I know that a lot of folks will take an epidural, and there is an effect because of the constant fluid. Once you have an epidural, you have to keep your fluids up so that the blood pressure doesn't drop. So they're getting IV fluid, and that will then soak into the tissue, including the breast tissue. And that can affect the nipple shape and latch. So what would you say to a parent that thought things were going well, and then they're like, what's happening now? Baby's not latching as well. How do they get past that hump
Yeah.
Yeah. I mean, and I'm sure you
It's
can explain it better than I did.
No, it's a great question. And this is where it's crisis mode. So really all those extra fluids, as you so beautifully described, absolutely can cause edema. And what is edema? Well, it's engorgement and engorgement you absolutely see in the breast tissue, which is so metabolic at that point anyway. And so, yeah, so engorgement or quote milk coming in is really severe. And we've had a lot of IV fluids. And it does take some specialty management in those cases. So, as we described earlier, when a baby comes to the breast, they really have to mold the breast to their unique mouth, mom's unique breast. And if the breast is so hard that the baby can't actually mold the breast and get the tissue into the mouth, then it's almost very much like bobbing for apples. All right. They're just coming on and slipping off, coming on, slipping off. So you really need to then, think about how are we going to support this transition when there's so much engorgement. And so that's where reverse pressure softening can be really helpful. Some hand expression, which I think is an amazing skill that everybody should probably learn, before a baby is born. And then we know things like potentially, if you have a lot of swelling, then ice can simmer things down and that can help, or some stroking of the breast towards the armpit, which is where the lymphatics drain. So that kind of assisting the body to, reabsorb the fluid while trying to get the baby latch. Those are some of the things that can help, because you're right, that engorgement from fluids can be severe. And that is right when we're starting to get cracks in the nipples, pain, moms are
And
almost
panic.
crying.
I can't tell you how many parents will come back and be like, I tried, it was going well the first few days, and then baby wouldn't latch. And then they were panicking, baby wasn't getting enough. And then they switched to formula because baby was hungry, couldn't get the latch. My body wasn't meant to do it. And they switched to formula, which is fine.
Yeah.
If someone wants formula, I don't want to poo-poo them. I just want, if someone wanted to try breastfeeding and they didn't have that support, I just want people to know, or I guess I'm hoping, and you explained it nicely, that we can get past that edema.
Yes. But you're exactly right. And so that 3 to 5 days postpartum is where we see crisis mode. We're worried about milk supply. Our breasts have engorgement. The baby can't latch. We have pain. It's extremely painful. And then there's, wound care almost that then has to be done to the nipple and areola complex because of the latch and how the swelling has then affected the latch. And so that is why the American Academy of Pediatrics recommends that these babies are followed up 3 to 5 days postpartum in general, but absolutely if they're breastfeeding. And when I was at the university, we had a clinic that addressed this critical time period. And this is exactly what we would see, just moms and, and parents and families in such distress because of where they were out on their journey, being, painful and worried about supply and a baby's losing weight. Because if you can intervene at that point, then you can make such a big difference, on the journey ahead and what the family wants that to look like.
Oh, that's so important. I'm so glad we fit that in. I hadn't even put that in our questions, but it popped in my head. I'm like, we must address. So what would you say to a parent who feels like feeding hasn't gone the way they had hoped, but they still want to feel confident and supported?
Yeah. So would that be their new journey or their current journey?
If someone is on the journey right now and they're like, this is not going how I wanted to, but they still want to feel confident and supported.
So you need your team baby. And I know you talk about this all the time, like who is your support team, like before you even give birth. And you really, it's important to express what your feeding choices are for you and your infant and what you want that to look like so that your team baby can then step in and support those decisions. But absolutely IBCLC, you need help and support. And really, thank goodness we have more IBCLCs now than we used to, and they should be in most hospitals, and especially if they're baby friendly, that is a requirement. But seek help right away. Even I would just say if you're going to breastfeed, that is, you need to set up that support system before baby's even born and think about that. Who are your resources in the community? Who are your IBCLCs? Think about the local La Leche League. Think about peer support groups, so breastfeeding support groups, because in the end, I think when, families can have that peer support, that's what gets them through at 2 a.m. when, they're just, it's really, that's that sundowning, right? When the sun goes down and baby's up all night feeding, and being able to reach out to somebody at 2 a.m. to get you through the night. We actually have a Milk League support group, and I can't say enough amazing things about those moms and how they support one another. They're each other's team baby, and they are just incredibly positive and just so vibrant in how they support one another. That, to me, that's been one of the most beautiful things I've actually appreciated in my clinic, is this peer support they offer each other.
Oh, I love that. I still remember with my first 3 a.m. freak out. Baby was not latching. I was crying. My husband was trying to calm me down. Luckily, my friend was an IBCLC. I think I texted her then, and a couple hours later, she was at my door. Like, we need help. Like, we can't do this ourselves. We need help.
Yeah. And it was life-changing, right? You will never forget that.
Never. I still remember her. Thank you, Andre. I hope you're listening. All right, we're going to take a quick break. When we come back, what is one final tip or piece of advice you'd like to offer new and expectant parents? And you can put any hat on. You could put your parent hat on, your pediatrician hat, your IBCLC and breastfeeding. Oh, there's so many hats. Medicine. You're a prenatal yoga teacher. You have so many hats. So we're going to take a break. Think which hat you're going to put on. We'll be right back.
Kaylee Cuoco and Sam Claflin star in the MGM Plus original series, Vanished. When the man Alice loves disappears on a train to the south of France, every romantic memory becomes evidence. Every intimate detail, a potential threat. She thought she knew everything about him, but she may not even know his real name. New episode Sunday on MGM Plus. Finding the truth is a dangerous affair.
Okay, we are back. I'm very curious where this is going. So what is one final tip or piece of advice you'd like to offer new and expectant parents?
Yeah, so I'm really just going to have to go back to the peer support and finding your team baby. I just think it's essential. I can say a lot of things to my patients, but until you found somebody that you can connect with and can get you through, the 2 a.m. Challenge, that is really what makes the difference. But I will also say, I think sometimes we, medicalization, gets into lots of areas of birth. But I do also think that that leads to medicalization in breastfeeding as well. So, always remember as a parent that you know your baby better than anybody. And it's important that if you have concerns or if something doesn't feel right, that you hone in on those, maternal or parent instincts that are telling you that something's not right. Because, and I wouldn't, silence that voice until you've had the opportunity to speak to somebody, because there is a lot of things that are happening postpartum, but intrinsically, if you know something doesn't feel right, then I would recommend seeking care, because that parents know their own babies and they know when there's a challenge that needs to be addressed. And so, just using your voice, I think is extremely important.
Oh, I love that. All right. Where can people find your work?
Oh, well, I have a clinic in Mississippi. It's Bloom and Grow Lactation. So when my IVF challenge, when I went through IVF, when I was finally conceived the twins, every day I sang to them Edelweiss from The Sound of Music, because that was one of my favorite songs. And so, as you know, one of the lines is Bloom and Grow, may you bloom and grow forever. So that's where my lactation clinic name came from. But yeah, my handle is Bloom and Grow Lactation.
And I'm going to take this opportunity to plug. You also teach prenatal yoga, and you are our very first PYC method licensee. So folks out there that like the PYC method, Leigh is teaching that in Mississippi at her studio, which is really exciting. So for years,
because it's the best, Deb. Because it's the best.
Thank you. So though we've had the PYC method now on the Upper West Side for 23 years, we've been online, but it has been a passion of mine for all that. We've had so many teacher trainees finish our program and then go off and haven't had the support of PYC. So now we're offering that support, and Leigh is our first one. So those in her area, you can get such amazing support through Leigh for so many things. It's so exciting how much you can offer your perinatal community. I'm so happy for you and happy for your community.
Oh, I'm so grateful to connect with you and what you do for all of us. So, Deb, thank you. You left an impact on me back in, what was it, 2021? And I have not forgotten it. So I appreciate all you do.
Well, I appreciate you too. Thanks, Leigh.
Thank you so much. Take care.
This has been an episode of Yoga, Birth, Babies, produced by Prenatal Yoga Center. You can catch us on Facebook, Twitter, Instagram, and Periscope. I'm Deb Flaschenberg. Thanks for listening.